And welcome. It is MR Safety Week 2024. And what better way to kick off the week than to start with a podcast with the one and only Toby Gilk on kind of the evolution of MR safety. Toby, thank you so much for joining me today.
My pleasure. My favorite topic, as always.
So, most people who are listening probably know who you are, but do you want to give us just a brief introduction about yourself, just in case anyone listening doesn't know who you are?
Sure. So Tobias or Toby Gilk. I am one of the founding board members of the ABMRS, the American Board of Magnetic Resonance Safety. I'm a two-time past member of the ACR's MRI Safety Committee and one of the contributing authors to the 2007 guidance document on safe MR practices, the 2019 updates and critical information, and then the 2020, but not the newest 2024 ACR manual on MR safety. I am a practicing architect, and I specializing in radiology and MRI facility design. And through that, got completely down the rabbit hole with respect to MRI and MRI safety. And I have my own consultancy, Gilk Radiology Consultants. And through GRC, I work with Metrosense, providing MRI safety information support for Metrosense customers.
And then my personal nickname for you is our MR Safety Vigilante. And so I hope you don't mind that that's what I call you, but that's what I think of when I think of Toby.
Strangely fitting. Yes. No.
So today we're going to kind of talk about the evolution of MR safety. I think a lot of people, when they hear MR safety, they think, oh, the Michael Columbini incident was essentially the first time MR safety came up. But that's not necessarily true, right? So MR safety at least made an appearance, maybe a very small one, but before the Michael Columbini incident. Do you want to tell us how it showed up first, at least to your knowledge?
Yeah, so I don't know necessarily the timeline of everybody's efforts on MRI safety, but in the United States, probably the first publication about MRI safety that wasn't an academic paper or something like that was from AAPM, the American Association of Physicists in Medicine. And I think it was 1985.
Wow.
They published what was then report number 20 from AAPM that dealt with MRI safety, but it was primarily in the context of sort of planning an MRI facility, making sure you knew where your Gauss lines were, making sure you didn't put two MRIs too close together, that you would get crosstalk and imaging interference, making sure that you had a closet or a space to store your liquid nitrogen dewars, with vents in case your dewer started to leak and you didn't asphyxiate everybody in the building. Interestingly, AAPM has never rescinded or updated that 1985 publication. So if you want to know AAPM's most current information on MRI safety, it's still that 1985 document. So that is, at least as far as I'm aware, is sort of the earliest MRI safety document that tried to speak broadly to the safety of the MRI environment, not just can we safely do this particular scan or scan patients in whom there is, fill in the blank, whatever that might be. So that was kind of that first resource. I don't know the specific timing, but MHRA, the UK's healthcare regulatory agency, they don't like the comparison because it's not exactly correct, but essentially MHRA is the UK's FDA. And they had published some safety guidance. I don't think it predated the AAPM guidance, but it was around the same time. But for whatever reason, that sort of safety guidance information never really crossed the Atlantic. It was not something that was, at least in my experience, widely recognized or cited.
Yeah. But now, so both of those documents occurred pre-Michael Columbini incident, which was 2001. Is that correct?
Right. Yeah. So I I think it's fair to say that the Michael Columbini accident and the original ACR publication about MRI safety that was really sort of spurred by that accident. I think it's fair to say that that was the first time that there was MRI safety information sort of directed at the full clinical
Yeah.
audience of techs and rads and radiology administrators. And the previous publications, certainly the AAPM one, is really kind of geared specifically to a physicist audience. And while it did begin to kind of touch on safety in the MRI environment, it was largely from sort of a technical and not a clinical or operational perspective. So while there were earlier documents in the United States, I think the ACR following the Michael Columbini accident was really sort of the first one that was fairly comprehensive, really comprehensive in its scope and who it was targeting.
For a clinical perspective. So then 2001 is the Michael Columbini incident. So for anyone listening who's not aware of that, unfortunately, a 6-year-old boy was struck by a ferrous oxygen cylinder in the magnet and eventually succumbed to those injuries. And that was kind of the shot heard around the world as far as MR safety goes. That was the incident where people started to kind of pay attention and say, hey, we have to do a better job at this. We have to have some sort of guidance for this. And so 2002 was when the ACR put out the first white paper, right? Is that correct?
Yes.
Okay. So kind of immediately following that Michael Columbini incident, we're going to assume that people, I think you have some information on this. I'll let you tell it, but the story behind the 2002 ACR white paper.
Yeah. So Michael Columbini wasn't by any stretch of the imagination the first MRI death that we had. We, MRI, have unfortunately killed a number of people. Now, prior to that, there are reports of prior MRI projectile accidents, fatalities in the United States that just never captured the public attention, never made it into the news. There are probably scores of patients who were injured or killed from negative interactions from old school, pacemakers or ICDs and MRIs. So while the Michael Columbini accident is probably the first MRI fatality that many people are aware of, it is by no means the first time that we killed somebody. So in response to that, the thing that made the Michael Columbini accident different is it wasn't kept quiet. There were news trucks. There was CNN parked outside of the hospital reporting, live from the front lawn of the hospital where this accident happened. And the entire United States knew about this accident because it was on CNN. Now, the public attention to that accident essentially sort of stirred everybody up, right? What are we going to do in response to this? And so the ACR formed what they called their Blue Ribbon Commission, which eventually became the ACR's MRI Safety Committee. So they formed this Blue Ribbon Commission specifically to look at MRI safety, not only the Columbini accident and the things that sort of contributed to that, but more broadly, right? What are the potential ways that people can be injured in the MRI environment? And what are safety practices that either eliminate that or significantly reduce the likelihood of those things happening?
Yeah.
So those were essentially the marching orders for that very first publication that came out, I think, less than a year after the accident occurred. So the accident occurred July 27th, which is why the MRI Safety Week is always the week that includes July 27th as a memorial, a recognition of that particular accident. And the white paper, the initial ACR MRI safety guidance, I believe was published in like June of the following year. So less than 11 months, which included essentially it was published in the peer-reviewed journal. So they must have formed the committee and written it in, a handful of months and then submitted to the journal to get reviewed and approved and published, in less than a year. So pretty remarkable speed of getting that out to the community.
And so the ACR white paper, we've kind of seen evolve over the last 22 years. So that first, you said, was a publication in a journal. And then we see some revisions, 2004, I believe, still calling it the white paper at that point. And then, Toby, correct me if I'm wrong here, was it 2006 or 2007 that the next one came out?
Came out in 2007. Would have come out in 2006, except that's when the whole NSF hullabaloo, sort of blew up. And they actually, the original intent was to publish it in 2006, but there was so much concern about nephrogenic systemic fibrosis that essentially they held the publication until they could collect more information and sort of address that specifically. So it was published in 2007. But you're absolutely correct by guessing both years, because both years are the right answer for when it was supposed to and when it did.
Yeah. So we have the initial paper in 2002, and then another revision in 2004, one in 2007, 13, and 19, and then 2007, 13, and 19, they have a little bit of a name change, right, where they call it the guidance document, right? So it's a guide. Now it's changed from the white paper to the ACR guidance document on MR safety. And then we see in 2020 and 2024, which is the newest version, it's now called the ACR manual on MR safety. And we've seen it kind of as MR safety has evolved, we've seen this manual evolve as well. Do you remember, Toby, the newest version has like 150, close to 150 pages in it?
Yeah, I think a little more. Yeah.
And the very first 2002 version, do you remember? I don't know if I've seen the 2002 version. Do you remember how many pages it had? You said it was published in a journal, so I'm going to assume that it's not 150 pages.
Yeah. Which is one of the reasons it's now, ACR published and called the manual instead of published in journals. Yeah, absolutely. I think the original one was probably on the order of 20, 30 pages, something like that. Wow. So the level of detail and sort of the breadth of scope of the document at every update, there has been almost nothing taken out of the document as it's evolved. Virtually everything that was in the 2002 or 2004 or 2007, all of those documents, almost all of the content that was added to those is in the most recent version. There have been some things that, because of changes in information, for example, in the original document, there was a concern about imaging pregnant patients, non-contrast imaging of pregnant patients in the first trimester. And as the body of literature kind of developed, they evaluated the new literature and they were like, we don't have any data basis for identifying first trimester as being of particular concern. And so elements like that have sort of come out. So there has been some continuous improvement of the content, which in some cases means guidance from earlier versions isn't in the later versions. But generally speaking, it's essentially been a growing body of knowledge over the last couple of decades.
Yeah, I wasn't a technologist in 2002. I started scanning in like 2011. And so for 13 years now, my personal experience with MR safety, how I've seen it evolved. So when I first started scanning, we didn't scan pacemakers. We weren't scanning like active implanted medical devices. Even coronary artery stents, they were okay for a 1.5, but it was after 6 weeks implantation. And then it was, okay, well, now you can scan them on a 1.5 or a 3T, but still wait that 6 weeks. And we know now, like, you can go get a coronary artery stent in and you can come in right now and have an MRI, and nobody bats an eye at that. So it's appropriate that we have seen these documents evolve as MR safety has evolved as well. Toby, let's transition and talk a little bit about how some other things regarding MR safety have evolved, not just the manual, but kind of like what I'm talking about as far as care goes. The complexity of our patients has gotten more and more, they're more and more complex now, sicker patients that we're scanning, more active implants. And then on top of that, some of the things that we've seen is the modality itself has evolved, has improved. So do you want to talk a little bit about how you have seen the modality evolve and the patients evolve, and then some of the challenges that maybe technologists are facing now as a result of those things?
Yeah. So if clinical MRI is essentially 40 years old, plus or minus, right? I think we need to look at the world of clinical MRI in a series of chapters, right? MRI as it was in the 80s or 90s has almost no resemblance to MRI in 2024. So one of the things is, if we look at the MRI technology over time, not just going from 1.5 to 3, but if you look around today, we've got the hyperfine roll around magnet, right? 0.064 Tesla. We've got new magnet formats and clinical applications. We've got specialty magnets going into neonatal intensive care units. We've got hybridized MRIs and linear accelerators going into existing radiation oncology facilities.
Yeah.
We've got MR PET, where we essentially marry all of the MRI safety concerns with radioisotope safety concerns. So the diversity of MRI devices is just one of the ways that over the decades MRI is getting more complicated. Mm-hmm. Now, I will grant you that those tend to be the exceptional devices tend to be exceptional, right? They tend not to be in your community hospital or something like that. So let's just look at the way that meat and potatoes MRI technology has changed over the years, right? Mm-hmm. So stronger gradients, more powerful RF transmissions, mm-hmm. Steeper spatial gradients, better active shielding, so that we get our magnetic fields in a smaller footprint, makes magnets easier, less expensive to site. Mm-hmm. Each one of these technical innovations in magnet design carries with them some small increase in potential risk. Mm-hmm. Stronger and faster gradients present more risk to the patient than slower and weaker gradients. Yeah. Lower SAR or B1 pulse sequences, lower is safer than higher. Mm-hmm. Now, some of those things are specifically capped and governed, and you can't go above whatever the value is. But we've essentially kind of worked up to the limits, the maximums that are permissible for these different values, these different elements of the MR study. So almost every innovation in MRI technology has ratcheted up the risk some small quantity. And so that's been happening over the last 40 years, right? Yeah. At the same time, folks who have gotten into MRI, just within the last 20 years, 15 or 20 years, won't remember that prior to 2002, 2003, something like that. Binks, the MRI safety cat, is coming to join me. Prior to that, there were big bold print disclaimers in an MR operator's manual that essentially said, under no circumstances do you put any patient who has any implant device, foreign body, wearing any jewelry, they essentially, the manufacturer said, on pain of death, you will not put these patients into the magnet, right?
Wow.
And it wasn't until MR conditional labeling and the FDA said, guys, you can't say that anymore because we, FDA, are now saying that these devices, if you follow the conditions, are safe inside the MRI environment. And so the FDA leaned on the manufacturers and they took out these big, legal disclaimers, right? So that happened roughly about 20 years ago.
Wow.
But still, in that moment, implants and devices, MR conditional implants and devices, were the exception. They were not the rule. And it wasn't really until there was a critical mass of MR conditional implants and devices. And I think the tipping point for that was really with the first MR conditional active device that we have. And that really kind of was the thing that broke the floodgates. And we now have all sorts of implants and devices, as anybody in MR knows. 40% of your patients are likely to have implants, devices, foreign bodies, tattoos, and depending on where you're located, that number can be much higher than 40%.
Yeah. So I think it's a good point, and I want to talk about this a little bit more. I didn't realize, I've only been a technologist for 13 years, so I didn't realize that conditional labeling was that, I'm going to call it new. 20 years to me, that's not a long time. When initially, Toby, I think, correct me if I'm wrong, but the labeling was MR compatible. Wasn't that what it was called initially? Was MR compatible?
Yeah. So the previous version of the labeling had 3 terms, like we have 3 terms today. So MR compatible was essentially meant for like patient monitoring devices or ventilators, things that aren't implants within the patient, right? Things that have sort of a function outside the patient. And that was to make sure that designation essentially was, will the MRI alter the function of this injector, this infusion pump, this patient monitor, right? And it was not so much about the safety of that object or device in the MRI environment. It was more about the degree to which the MRI might change the function or reading or output, or, what volume it was ventilating the patient at, or, how many liters of oxygen were being delivered. So MR compatible was a term that was really sort of geared towards the function of a piece of equipment or device. In addition to that, we had MRI safe and MRI unsafe. Now, MRI safe, the old version of the term, was roughly equivalent to our contemporary MR conditional, right? It was safe if you follow the specified conditions. Well, that message that, that there were conditions of safety associated with it was not sort of embedded in the name. And there were a number of accidents where people were like, well, it said that it was safe. It had the label that said MRI safe. So the FDA and the ASTM essentially were like, oh, okay, if people are misunderstanding, the terminology here. So then they shifted and they're like, it may be confusing to folks that we have terminology both for functionality, right? Will the device function be altered? And for safety, right? And then also our description of what constitutes safe, probably not all that clear. So I think this was 2002, 2005, something in that general time frame. They discontinued MR conditional. They're like, we will have separate conversations about the functionality of equipment and devices. We're just going to focus this terminology strictly on safety of objects, devices, implants in the MR environment. So they continue to use MR safe, But in kind of the absolutist terms that people were misinterpreting the old version of it, right? If it's labeled MR safe, it is safe in all MR environments, right? So that's how that particular term sort of evolved. Same term or very similar terms as like the old version. Old version meant to include conditions, but that wasn't very clear. So they were like, okay, fine. People think that it means absolute. We'll make it absolute. And then they introduced MR conditional as, you know, sort of the fill in the gap, right? So that the name, you know, identifying that there are conditions associated with safe use, that was now embedded in the name.
So the term MR compatible is just sort of outdated. It's not applicable anymore. I always kind of joke and say, well, they're not going on a date. We want to make sure that they're safe, not compatible. But so that's a great history on that, because I didn't know that came about such a short time ago. So I guess I'm going to assume, and you correct me if I'm wrong, 20 years ago when we were saying the devices were conditional, or not conditional, but compatible or MR safe, are you aware, Toby, of people scanning any implants off label at that time?
There's always been off-label scanning. Now the question is, did they mean to? So there's always been, you know, either a failure to screen effectively or a failure on the part of the patient to disclose information. Remember, you know, 20, 25 years ago, we didn't have Epic, you know, with an implant tab. You know, every piece of prior medical history that we had about a patient, you know, might as well have lived on Mount Olympus, right, in terms of our ability to access that information. So every piece of previously collected patient information was essentially dead to you as an MR tech at the point of care. The only thing you had to go off of was that the screening form that the patient filled out, you know, 10 minutes before you were supposed to walk them back into the scanner. And anything they remembered to put on that form, you had that access to. Anything they forgot or chose not to put on that form, you didn't know, right? So before, when I talked about how, you know, unfortunately in the history of MRI, we've killed scores of people, a lot of that was implants and devices, either that we failed to screen effectively, didn't ask the right questions, didn't recognize it as you know, the threat that it was, or patients didn't disclose, and we walked somebody into the room and the bad thing happened, right? So that has shifted over time. The relative risk of those implants and devices has shifted over time. To the point where the technologies that have been developed specifically for pacemakers, for example, for MR conditionality, those technologies have been backfed into the design of pacemakers, even the ones that don't have MR conditional labels.
Wow.
I'm not suggesting that, you know, the non-MR conditionally labeled pacemakers are just as safe in the MR environment as the labeled ones. I think that would be a gross misstatement. But the things that put so many pacer patients in mortal jeopardy, you know, in terms of walking into the MRI room 30 years ago, those aspects of the design of pacemakers have been changed rather substantially, so that those risks are significantly lower than they were, you know, 30 years ago.
Yeah. So I often hear technologists express concern about scanning implants off label. I'm going to be careful not to go down a rabbit hole here because I think this is something we could probably do like an entire podcast just on this. So I'm going to be really careful.
Or 2 or 3 or 5.
But I think a lot of people think, okay, well, FDA tested it and they said these are the conditions that it has to be scanned under to be safe. And I think there is this misconception that they test it to failure, and if you cheat that a little bit, it's going to cause harm. Was that my understanding is that that's not the case, that the FDA, when you go to get FDA testing, you're just testing it to be able to market it, to sell it. So my understanding, and please correct me if I'm wrong though, is that these devices are not tested to failure. So if we scan things off label, that doesn't necessarily mean there's an inherent risk. It's that we have to have the knowledge to do that. Is that one, I guess I'll say, is that a correct understanding of that? And then two, has it always been that way? Even 20 years ago, were they ever testing implants to failure?
So yes, the baseline understanding of how things are today is correct. So the way that FDA testing and labeling is done for a new implant, a new device, right? The manufacturer, let me rewind. Up until very recently, the FDA told implant and device manufacturers, if you're not going to make any marketing claims about the safety of your product or device, in the MRI environment, then you don't have to provide any labeling for MRI, which is why historically there's been a proliferation of implants and devices that either don't mention MRI at all, or when they mention it, it's this device has never been tested for MRI safety, right?
Mm-hmm, mm-hmm.
Good luck, you're on your own, was essentially what that was. So within the last few years, FDA has, I don't know if it's an official rule or just a recognition that, oh my God, look at the number of people that we put into magnets in any given year. Mm-hmm. It's ridiculous that we bring implants and devices to market without having some basic information about the safety under this test.
Yeah.
Whatever their motivation was, the FDA is now indicating that most new implants and devices that come to market have to have MRI safety testing information. The way that a manufacturer gets an MR safety label, MR conditional label, is they say, hey, FDA, we've either tested or developed sort of a scientific rationale because we've looked at other products that are similar or other materials, and we can make judgments or determinations about the safety of this product or device based on whatever that information is, right? Mm-hmm. So let's say that you're a company that wants to bring a new pacemaker to market, right? You might be able to say, hey, our pacemaker looks an awful lot like the other guys, right? Yeah. It's made from the same materials. It's about the same length, right? Mm-hmm. The other guys label theirs for 1.5 normal mode, right? Yeah. I'm vastly simplifying sort of the illustration here, but you might be able to get some literature and sort of say, what? Ours is not any worse from a safety standpoint than theirs is. Mm-hmm. And we have this literature and, parallel testing kind of information to be able to go to the FDA and say, look, we don't think you should make us test our new pacemaker a million ways from Sunday. We think we've got enough evidence to essentially support, whatever you gave those guys, you should give us as well, right? Yeah. And if you come with a strong enough argument and support data behind your argument, the FDA may look at it and go, you know what, you're right. Yours doesn't appear to be any higher risk than those guys. You should have the same label as it, right?
Yeah. Yeah.
In that scenario, nobody has ever said, at what point does this device cross from being safe into unsafe, mm-hmm. right? Mm-hmm. The FDA does not require either that you identify where that safe to unsafe tipping point is, mm-hmm. Nor do they require that any label tell you anything about where that tipping point is. Mm-hmm. So whatever information, whatever sort of safety limits a manufacturer wants to prescribe for their implant or device, and that can be for any reason, right? That could be the testing house where we have our devices tested only has access to a 1.5 Tesla magnet, right? So we're only going to label it for 1.5 Tesla.
Yeah.
Might it be safe on a 3T? Sure. Who knows, right? Yeah. We tested it on 1.5. We get it labeled for 1.5. So it could be something as mundane as, yeah, the guy we had do this only had, access to one magnet. And so that's what it's labeled. I was actually working with a company. They had, they jumped on the bandwagon early 2000s when MR conditional labeling came out, and they had a product and they were like, oh, we should go get this labeled. So they went out and got it labeled with what was, in 2003, 2004, sort of top of the line performance specs for it, for spatial gradient and whatnot. And, fast forward 15 years, and they're like, yeah, we keep on getting all of these calls from folks who have newer magnets with higher spatial field gradients. And we're essentially having to tell them, look, it was only tested and labeled to, 540 Gauss per centimeter or whatever. Yeah. And so they're like, do we need to get it retested? And I was like, well, if you have access to the test data, not necessarily. You can actually apply this calculation, right? An extrapolation. If you know what it was exposed to, you know what the deflection angle is, you can do this extrapolation. And the FDA has accepted that as a scientific rationale in the past. And they like to make it fairly easy for groups to update their labeling and kind of expand the definition of safe use of conditions. So I gave them the information. I sent them the calculation that the FDA has accepted before. And 2 weeks later, I get this letter. Thank you very much. We're preparing the submittal now. This is the language that we're, going to be submitting. And I went through and I checked their math, right? And I was like, oh, guys, you did the calculation wrong. So you came up with a number that is higher than what your label was before. Mm-hmm. But because you did the math wrong, it's only half as high as you could be, if you did the math correctly, right? Mm-hmm. And the calculation has a 30% safety factor built in. So it's not like you're, right up against a safety threshold or anything. Mm-hmm. So I sent an email back to him. I was like, guys, if you haven't submitted this to the FDA yet, you should really correct your math. And oh, by the way, it's going to get you, this much again, sort of margin in terms of new magnet systems or whatever that come out. And I got a response back that essentially says, yeah, our attorneys essentially think this is good enough, that even though the math is wrong, that they don't see the need to kind of push it to what is the allowable extrapolated limit. Wow. Because they were concerned that somehow that might introduce additional liabilities to the company. Wow. So even when the company knows what what that tipping point between unsafe and safe is, even if they know what it is, they're not obligated to share that information with us. So whatever point they want to set and have the information to support, that's what a label can be. So yes, going off label, depending on the particular device and the patient and the study being performed, going off label does not necessarily have to represent any increased risk to the patient. In fact, I've done this exercise in a lot of the courses I teach, where I talk about, I think it's based on an old Medtronic deep brain stimulator. I think the conditions were 1.5 Tesla only, 0.1 watts per kilogram, transmit receive head coil only, right? Mm-hmm. And I'm like, what if you did that patient's knee? Right? Everybody's like, oh God, that's off label. We might fry their brain. It's like, okay, well, let's think about it, right? So if you're doing a knee, if you had a TR knee coil, right, then the RF exposure on that implant is essentially zero, right? You wouldn't even need to constrain the study to that 0.1 watts per kilogram, which is probably a good thing because the patient will be in there for a week and a half to get a good study of their knee. So absolutely blast that knee, with 20 watts per kilo, local SAR. And it will have no impact on that pulse generator. Yeah. And there are a bunch of other steps to kind of go through for that illustration. But the long and short of it is there may be off-label studies that are safer for the patient than the labeled study. Yeah. So off-label does not automatically mean, more dangerous.
Right. And I'm going to do a little shameless plug here, Toby, but if off-label scanning is something that is of interest to anyone listening, we MetroSens, along with you, Toby, are hosting a 2-hour webinar Friday. Is Friday what is Friday, the 26th? Yes.
26th, I think.
26th,
yeah.
on just specifically off-label scanning. So if this is of interest to you, I highly encourage you to register for that and attend. I'm sure there's going to be a lot more pearls of wisdom that come out of that. But thank you for talking about that. And like I said, I want to try to, I didn't want to get us too far down the rabbit hole because I knew that could be a topic that we could talk about for days and days and days.
Absolutely.
So, yeah. So what I'm taking away from that, FDA approval conditions, they're important to have. We want to make sure that implants are safe, but it's not like a hard stop. It's kind of a guideline, and if you have the knowledge and you can assess it for the risk and the benefits, and you can say, hey, like you were just saying, if you go off label, it doesn't necessarily mean that this is an unsafe exam. It's just you have to have that knowledge to know how to assess it to maintain
Yes.
safety. So since we've talked about that, let's talk a little bit about now what regulations are there in place, or are there any regulations in place regarding MR safety?
So this is going to be a real short part of the podcast. In the United States, we do have regulation over the MRI device. So things like the definition of what's normal mode and what's first level mode, right? Information that has to be provided, to the buyers, I guess, of MRI equipment about, safety parameters, safe use of that device, that kind of thing. So the FDA regulates that, and the FDA doesn't really write their own regulations for that. They look to international standards, and the FDA goes, hey, the IEC, the International Electrotechnical Commission, the IEC, you guys have got a really strong body of standards. You've got the participation of all of the MRI manufacturers. We think that your standards should be our standards. And so, the FDA adopts the IEC standards for the safety of the device. The FDA, and I was really surprised when I first learned this, unless we're talking about mammography, the FDA does not regulate point of care, the delivery of healthcare for any radiologic device. Now, I single out mammography because it literally took an act of Congress, the MQSA, Mammography Quality and Standards Act, that gave the FDA jurisdiction over quality and safety of mammography services at the point of care. So if you aren't mammography, FDA is not in your business at all, right? Mm-hmm. Okay, so from a federal standpoint, no real regulation of MRI safety. Next stop would be the states. States, by and large, have consistent regulation of ionizing radiation, radiologic devices. And that's largely because the states cribbed radiation protection safety standards from the Department of Energy. DOE developed them during the Manhattan Project, and as workplace safety rules for folks working on nuclear weapons projects. And so we had ionizing radiation tolerances and thresholds and exposure limits and ALARA and all of that sort of stuff. We had that from the Department of Energy. Mm-hmm. So when we discovered that clinical use of X-ray and fluoro and ultimately CT and nukes, that there were these risks to both patients and to workers in those environments. We're like, what are we going to do? Oh, wait a minute. DOE did this for us, workplace safety rules, right? And so those largely got appropriated, which is why ionizing radiation safety standards are so consistent across the United States, even though that's regulated at the state level, right? So when MRI comes around, everybody's looking around. Last time we got to crib the notes from the Department of Energy, who do we get to crib safety notes from this time? And everybody's looking around like there are no safety notes for this. You know, okay, we're all worried about ionizing radiation exposure, and you know the MRI folks are like, yeah, we don't got that.
Yeah.
They're like, well, you don't have it, and nobody else has any rules. I guess we're good to go. And that was sort of the beginning, middle, and end of the conversation of regulating MRI at the state level.
Wow.
Recently, in the last year or two, there have been quite a number of accidents in the state of California, and I've wound up becoming a whole lot more familiar with like California regulatory information than I ever wanted to be. California, in their state laws or state codes, don't acknowledge that MRI exists. There is literally no regulation of MRI officially, you know, within, you know, state codes or whatever. The state code that governs radiology essentially says ionizing radiation devices such as, and then it, you know, lists X-ray and fluoro and CT and, you know, nukes, and it says and non-ionizing devices, ultrasound and thermography. So whereas ionizing, it's all ionizing, for example, but the non-ionizing, it's if you're not ultrasound and you're not thermography, the California state code doesn't, it's not even in there. And I've gone round and round with folks in that state about, you know, who has specific responsibility for this. And every part of the Department of Health agencies that I talk with is like, well, it's not us, but we're sure it's those guys over there, you know. And then you get to those guys over there and they're like, yeah, no, the radiology folks, you know, they're like, no, we only do ionizing. So even within the state government, you know, it's not only are they not sure whose responsibility it is, in many instances, it's not even, you know, defined as something that can be regulated by the state. So the states are more or less completely out of it. Now, there may be reviews from the Department of Health in terms of siting, you know, and they may say you have to have 4 zones when you site it and that kind of thing. But operationally, day to day, after the building is built, nothing from essentially all of the states. So then, okay, who else might we look to? The accreditation organizations. And each one, well, I shouldn't say each one, most of the accreditation organizations describe MRI safety in some general terms. Even though the ACR, you know, has published the white paper ×2, the guidance document ×2, the manual ×2. And so the ACR has developed this incredible body of MRI safety guidance. ACR accreditation doesn't invoke that. In fact, if you look at the specific site requirements for ACR MRI accreditation, and you compare those with, say, Joint Commission, who isn't exactly known for publishing, you know, lots of useful information about MRI safety, Joint Commission accreditation criteria are more specific about MRI safety than the ACR's MRI accreditation. Which kind of blows my mind. And both of those are better than DNV, which is one of the hospital accrediting organizations. Joint Commission is probably number 1 in market share. I think DNV is probably number 2 on the hospital side from market share. DNV's accreditation criteria don't mention MRI safety once. There are 0, you know, sort of minimum objective criteria in the DNV accreditation for this. So if you want to, you can shop around. If you're concerned about somebody, you know, the heavy hand of regulation, you know, cramping your style in MRI and MRI safety, you can shop around and you can find accrediting organizations who are like, yeah, you tell us what you want to do. So from a regulatory standpoint, MRI is the Wild West. And there's almost nothing substantive that is actually sort of minimum level of care requirements. I think anybody who has ever been through a Joint Commission accreditation survey or has a friend who has, will tell you stories about, well, where are your zone signs? That was, at least for a number of years, one of the big, safety accreditation checks, is that you have zone signs, right?
Wow.
I was at a facility that had just undergone their survey, Joint Commission survey, like a month before I got there. And the big thing at the time was making sure that the little wire tag that held the inspection tag on a fire extinguisher, that tag was plastic and not metal, right? Because if it's metal, it might go flying, right? Which was nonsense. And so I walked into the site, and the Joint Commission was right here, and they were all proud that they had gone through and they had replaced their metal twist ties on the inspection tags with zip ties and that kind of thing. And I was like, so did the surveyor come in here? And they're like, yes. I was like, did you guys have lots of advance warning and you kind of, cleaned the place up and made everything look pretty? And they're like, no, really, they just kind of showed up one day and we weren't expecting them, and, pretty much what you see here. So against the wall where the fire extinguisher cabinet were two wheelchairs from the floors and an unsafe, IV pole with an infusion pump that came down with a patient from the floor, that was all essentially stacked in front of where this fire extinguisher cabinet was. So if that was the condition when the surveyor showed up, they would have had to move all this unsafe, large chunky things that can go flying at the magnet,
to worry about
things that we normally have patients with or in or on. To go look at the little tiny, 1 ounce wire tie for the inspection tag. So even when we have, regulation or, standards of it, a lot of times those are checkbox kind of things. They ignore the thing right in front of your face, right? If this wheelchair went into the room, somebody could die, right?
Yeah.
In order to look for the wire twist tie on the inspection tag.
Yeah. So I want to talk a little bit now about the ABMRS, because I do think the ABMRS has made an initiative to try to make facilities safer with their certifications. Correct me if I'm wrong, but you were one of the founders of the ABMRS. Is that correct? Okay.
That
Do you want to
correct.
tell us a little bit about how that evolved and what caused this to come about?
Sure. So 2015, 2014, ISMRM and essentially most of the world's other alphabet soup organizations that are specifically interested in MRI sent representatives together, essentially sort of an author pool from across these organizations from around the world. And they wrote, I'm probably going to mess up the title of the paper, but it's like MRI Safety Responsibilities. And in that paper, and the paper, by the way, is free. Google it. It's not behind a paywall. Plus, it's only like 3 or 4 pages long, so it's a real short read. In that document, they essentially said, look, for MRI safety, while yes, MRI safety is everybody's job, right? We need to have individuals who are specifically appointed with responsibility. And this is not, some sort of novel concept. On the ionizing radiation side, we do this all the time, right? You have to have an RSO. You have to have a physician supervisor, if you're going to get a radioactive materials license. You have to have a radiation safety committee. It has to meet quarterly. You have to have, ongoing minutes, all of this sort of stuff. We have these structures in place for governance on the ionizing radiation side. And what this group of authors, different organizations essentially did is, we need to have a parallel structure in MRI. And so they published this paper, and the paper says, every site should have an MR medical director, MRMD. Every site should have an MR safety officer, MRSO. and you should have access to somebody who is a phone a friend, resource when the physics or technology of something gets kind of hairy, and that's an MR safety expert, an MRSE. So they published this paper. I think it kind of was released pre-publication in like 2014. It was officially published in 2015. So the ABMRS was like, yes, that is a good idea. But we should also have some means of measuring knowledge competence of the individuals who are going to serve in these roles, without some sort of metric of knowledge performance. We can give these titles to anyone we want. My cat Binks, he can be an MRMD if he wants to. So that it's not just kind of figurehead, a body in a seat kind of thing. We should develop these standards. So the ABMRS, starting in 2015, actually began administering certification exams. The board of the ABMRS is comprised of some of the most brilliant minds in MR safety. Physicians, technologists, physicists, folks from standards bodies. So it's really, tries to be a comprehensive view on that. So 2015, ABMRS starts administering these certification exams for MRMD, MRSO, MRSE. And so that's, oh my God, next year that'll be 10 years. And there are thousands of people, mostly from United States, Canada, North America, but people come from all over the world to get this credential. And there are, I think every continent except Antarctica, we've got certified one or more of these credentials. And it's amazing to see. I think those individuals really have been a huge catalyst for elevating the conversations about MRI safety. And I think we see much more sophisticated and empowering information about MRI safety in the last, 5 years in particular. And I think that's largely because now we have individuals that, know their stuff and can demonstrate it unequivocally. They got proof that they know their stuff.
Yeah, it feels like ABMRS certification is catching on. People are starting to realize that it exists and the impact that it can have on their facility. I am not aware of it. You might be, Toby. Is there any data out there that supports that if your site has these 3 people appointed, is there any correlation to safety in that regard, or is there any data out there that supports that? Or
I don't think that there's data specifically for that, but there is a paper that's out there. It was published in the AHRA, the Radiology Healthcare Administrators Professional Group, in one of their publications. Maybe as long ago as like 10 years ago. The author is Wendy Sternkorb, and she published a paper about the results at her facility when she got a number of her senior MR techs essentially trained. Doesn't correlate specifically to the certification. Some of them did get certification. Others just got the training. But it talks about how they increased productivity without increases in staffing by virtue of the fact that patient clearance was no longer in many instances not well, we have to wait and get the records for this. And to your previous example of the patient who had the coronary stent, that we used to think, oh my God, we have to get full documentation before we can clear this patient, right? By understanding how to categorize and quantify the risks, you can begin to take a look at the patient who has, a couple of coronary stents in them and go, oh yeah, no, we're not worried about that at all. Whereas once upon a time, that would have been, oh my God, I have to delve into this patient's medical record. They got the stents placed in a different institution. I have to, call the referring cardiologist. Cardiologist doesn't know what stock was at the hospital where they did the procedure. Now I got to call that hospital and I got to try and find out what they were stocking, 8 years. So a simple question like that could very easily wind up, delaying patient care for a week, right? And disrupting schedules and leaving empty time slots and all that sort of stuff for something that today we're like, oh, coronary stent, go ahead. So if you imagine that kind of example times thousands of patients who are going to have different types of questions or complications, you can see that there could be, sort of massive time savings and massive reductions in patient delay and patient refusals for exams. So she wrote this paper essentially quantifying the before and after at her site. And the results were really remarkable. I mean, very substantial increases in patient throughput because of lack of a reduction in the labor associated with clearing patients. Greater patient accessibility because patients who, previously we thought, well, we can't do them or we can't do them unless we check these 17 boxes, that those patients could actually gain access to MRI. So to your specific question about, evidence of the credential making an impact on those kinds of things, I have yet to see data like that. I would absolutely love to. I suspect it would bear out the way that the Stern Corp article does, and that's, the addition of that knowledge and competence in the folks, doing the evaluations and making clinical decisions, has a huge impact on patient accessibility and the speed with which we can identify whether something is safe or not.
Yeah, I agree. So in the last 22-ish, 23-ish years, what would you say overall? I mean, I feel like, unfortunately, it's not uncommon to get on social media and at least weekly see, oh, there's been another incident. And unfortunately, Toby, that's not even all adverse events. That's mostly just projectiles, right? Because those are the ones that get a knee-jerk reaction out of you. But we still see incidents occurring. How would you score us over the last, MR as a whole, over the last, we'll say since 2001, we'll say maybe since 2002. So over the last 20-ish, plus or minus a few years, would you say overall we've gotten better, or would you say we have gotten worse?
Can I say yes? We have gotten better. Right. So the knowledge, the information that is available to MRI providers in terms of, how we can allow more patients to receive MRI studies safely. The ability to kind of share information about when conditions are safe or aren't safe, that kind of thing. So those channels and that information has grown significantly. So access to information better than it ever has been. Access to high quality, safety directing information better than it ever has been. But at the same time, if you look at like the trajectory of MRI accidents over that 2-decade time frame that you're talking about, they're growing, and they're growing faster than the number of MRI studies that we're doing. So even though we are improving, we're not improving faster than the risks are growing, right? So are we better than we were 20 years ago? Unequivocally, we are better than we were 20 years ago. Is that enough? Also unequivocally, no, it's not enough. We have been sort of gradually evolving in terms of operational models and knowledge, expectations, and skills, and that sort of thing, while the nature of the risks has been just catapulted ahead mostly because of implants, devices, foreign bodies in the patients that we have. I mean, yes, my prior statements about there being risks associated with changing MRI technology, absolutely true, over that 2-decade time frame. But I think that more than anything, it's allowing more patients with more complications, to come to MRI, and the difficulty in dealing with that. And we need some rather significant workflow modifications, shifts. And some of that involves what you were just talking about in terms of, identifying folks who are trained or certified and have demonstratable competencies in those areas. That's a piece of it. We need to be smarter about how we identify patients with risks. I was working with an institution that is actively trying to harvest data from their EMR, right? So if we have all of these billing codes, we've been seeing this patient at this hospital for the last 10 years or whatever. Why can't we essentially say, well, this is the CPT code for having implanted a pacemaker in that patient? If that CPT code exists in that patient's medical record, how come it's not a part of sort of the automatic flagging for MR safety screening for that patient kind of thing, right? So utilizing the information that exists that just hasn't really been collected or presented to the right people at the right time for MR safety screening. So I think that there are a lot of potential tools and methods of improvement. A lot of it is personnel based, let's train these people, let's get them the skills that they need to do the job most effectively. Part of it is policies and procedures, right? Let's make clear how we're going to screen and evaluate these patients who do have complications, contraindications. And some of it is leveraging technology. Let's make sure that we get the highest quality and most complete information about what the risks may or may not be, in front of the folks who are doing the assessment or evaluations. So we've got a lot of work to do. Yes, we have gotten better. But we have not gotten better enough, fast enough, as a profession. Now, while I'm making this generalization about, MRI care and radiology across the board, it's important to recognize that there are outstanding providers out there who, get this and have internalized this and are actively working at this. But, and this goes back to your question about, sort of regulation or oversight. There are those sites who will do what their reimbursement is contingent upon, and nothing more. And so those foot draggers are the ones who are sort of bringing down the average for everybody. It's the class project with the guy who never shows up, right? The guy who never shows up is on our team, and I think one of the things that would make the biggest positive impact in MRI safety is having some sort of minimum level standards that are useful to the safety concerns that we face now, that essentially make the foot dragger, on the group project at least kind of carry the minimum amount of weight associated with this.
I agree.
If we can raise the floor, raise the minimum expectations for those guys, I think that will make an outsized positive impact in improving MRI safety across the board.
Yeah, I agree. All right, Toby. So we're going to wrap up here, but I'm going to put you on the spot and ask you, let's say someone is listening and they're over an MR department. And I think it's not uncommon for people that are over MR departments not to be MR registered. So let's say it's someone who they have no idea about MR safety and they're like, where do I start? Can you leave any of our listeners that are looking to start somewhere? Can you leave any sort of advice for them? Do you have anything that you would say might make the most impact, get the biggest bang for your buck?
Yeah. So the situation you describe, I think, is not at all unusual. There are lots of radiology managers that maybe come up through the X-ray and CT side, and the ionizing stuff is really familiar to them, and that's something they feel comfortable managing. Or somebody who is brought into radiology with management expertise, but not maybe necessarily radiology, clinical care expertise. So that situation you describe, I think we see a lot of that out in radiology today. So I would say the thing that's most likely to get you the greatest bang for your buck is the appointment of individuals into those roles. Make sure that you have an MRMD from your physician group, right? Make sure that you have an appointed MRSO. And depending on the scale of your organization, maybe you're of a size where sort of a dedicated, enterprise MRSO is appropriate. But if you're in a smaller organization, that can be like a senior MR tech who we don't take them away from scanning duties, but we carve out some of their time and make it available to doing these consultative kinds of things, patient clearance related stuff. Hopefully there's some new CPT codes that have been proposed, and we might actually get reimbursement for some of this stuff that we've been doing for years, right? So everybody keep your fingers crossed for new CPT codes. But I think the thing that can be done that can have the greatest outsized positive impact on MRI safety, if your institution hasn't done it, appoint individuals, the MRMD, MRSO. If you have in-house physics, and MRSE as well, if you contract out your physics next time your physics contract comes up for MR, tell them you want to add MRSE services to that contract. Putting people in those positions is part of it. Make sure that you get them the training and ideally the certification that kind of goes along with those roles. But I think having individuals who have both responsibility and authority over MRI safety specifically, I think that's a necessary catalyst to making any change that's really going to come after and stick with an institution.
Yeah, Toby, I think that's great advice. And I love that we couple that with, hey, don't just appoint these people, but appoint them and then support a formal education for these people and then continue to provide that support past that certification, right? I think that's great advice. Toby, thank you so much for joining us today. I think this was the perfect kickoff to MR Safety Week, and I think that our viewers will think so as well.
Thank you very much. My pleasure.